Hello. I would like to thank the organizers for inviting me and for giving me the opportunity to present the results of ADAGE study, ADAGE for assessment of direct oral anticoagulant pharmacokinetics and pharmacodynamics evaluated by thrombin generation in geriatrics. Here are my disclosure. Atrial fibrillation is common in patients 80 years aged 80 years and over. Current guidelines recommend the use of direct oral anticoagulants as the first-line treatment in patients with atrial fibrillation. However, the management of anticoagulants is challenging in the very elderly because they are at high risk of both thrombosis and bleeding. Indeed, they have frequently numerous comorbid conditions, including chronic renal impairment, and they are often polymedicated, thus potentially altering drug PK and PD. In the literature, only few specific data are available regarding DOAC, PK, and PD. Therefore, we conducted the ADAGE study. The inclusion criteria were the following. This was, an academic, prospective, multi-center cohort study. The inclusion criteria were patients aged 80 years and over recruited in 5 university hospitals. They were receiving rivaroxaban or apixaban for atrial fibrillation, and DOAC was taken since at least 4 days, the regimen being at the discretion of the physician. The exclusion criteria were acute unstable comorbid conditions and an estimated life expectancy less than 1 year. The aims of our study were firstly to characterize xaban concentration time profiles and to determine the potential impact of individual patient characteristics at Tmax and Tmin. Secondly, to perform thrombin generation assay in a subset of patients and to evaluate the potential influence of individual characteristics on TG parameters. Thirdly, to determine the incidence of clinical events at 6 months, but I won't show the results of clinical events today. Blood samples were collected by venipuncture into a single citrate tube, in addition to samples taken as part of usual care, thus without extra venipuncture in these frail patients. A maximum of 5 samples was obtained over a 20-day period at different time points, as you can see on this slide. The time since the last DOAC intake was carefully recorded. And then we classified the following time points according to the time elapsed from the last oral intake to define Tmax and Tmin for each xaban, rivaroxaban taken once daily and apixaban taken twice daily, as shown on the figure. PPP was prepared by double centrifugation and stored before central analysis. Xaban concentrations were determined using chromogenic assay with dedicated calibrators and controls. Thrombin generation assays were performed on ST Genisia system from Stago. TG thrombin generation assays were performed using different regions. First, STG drug screen corresponding to a relatively high tissue factor concentration, and thromboscreen with an intermediate TF concentration, the latter with or without thrombomodulin. Moreover, samples of pooled normal plasma were spiked with varying concentrations of xaban. Here are shown examples of different TG profiles for a patient with an apixaban concentration of 48 nanograms per ml, with drug screen on the left, thromboscreen without thrombomodulin in the middle, and finally thromboscreen with thrombomodulin in the presence of thrombomodulin on the right. We tested the relationships between prospectively collected characteristics and two criteria. First, xaban plasma concentrations at Tmax and Tmin, and second, peak height measured using a thromboscreen without thrombomodulin at Tmax and Tmin. We then perform a univariate analysis and then multivariate analysis using multiple linear regression. 215 patients were included in the ADASH study, 104 on rivaroxaban and 111 on apixaban. Here are shown the patient characteristics. The mean age was 87 years. More than 2/3 were females, as expected in this age group. CSG score indicated substantial polypathology. As you can see, characteristics were similar in both groups except for hemorrhage and CSG scores, which were higher in the apixaban group. More than 3/4 of patients received a reduced dose and less than 1/4 the full dose. Notably, 40% of patients did not receive the dose according to summary product characteristics criteria, of whom 90% were underdosed. And this is probably due to the prescriber fear of bleeding in these frail patients. The mean number of co-medications other than xaban was about 6, confirming polymedication in this age group. And nearly half of patients took a PGP inhibitor. About 20% of patients received amiodarone. On this slide are presented the rivaroxaban plasma concentration time profiles. Patients receiving 10, 15, or 20 milligram rivaroxaban once daily are represented with white, red, and gray circles, respectively. The mean concentrations and the 5th and 95th percentiles reported at Tmax and Tmin for patients included in clinical trials, especially in ROCKET trial, are represented with solid and dashed lines, respectively. We can observe a great variability of results at both Tmax and Tmin, as indicated by a high coefficient of variation. At Tmax, 1/3 of patients had values above the 95th percentile of reported ranges or below the 5th percentile, respectively. At Tmin, we can observe that the dispersion of values was much lower. Now are presented the apixaban plasma concentration time profiles. Patients receiving reduced or full dose are represented with blue and black circles, respectively. The mean concentrations and the 5th and 95th percentiles reported at Tmax and Tmin for patients included in clinical trials are represented with solid and dashed lines, respectively. And we can also observe within this apixaban group a great variability of results at both Tmax and Tmin, as indicated by high CVs. Again, we observed a great dispersion of values at Tmax and at Tmin in this group. I will present you now let us move to thrombin generation results using drug screen, namely the reagent with the highest concentration of tissue factor. Here are shown the results of lag time and time to peak as a function of rivaroxaban concentrations on the left or apixaban plasma concentrations on the right. Yellow points correspond to 10 milligram dosage, red points to 15 milligram dosage, and blue ones to 20 milligrams, gray ones to 20 milligram dosage of rivaroxaban. Moreover, spike plasma are represented by green diamonds. As expected, we found close relationships between temporal parameters and xaban concentrations. You can see now the results of PIC8 and ETP. There were strong associations between PIC8 and xaban concentrations. Interestingly, for a given concentration interval, for example, between 100 and 200 nanograms per ml, a great dispersion of PIC8 values was observed. The relationship with ETP was statistically significant for patients on apixaban, but not on rivaroxaban, as already described in the literature. You can see now the results of PIC8 and ETP obtained using thromboscreen, with a lower concentration of tissue factor. Similar results were obtained with a substantial variability of PIC8 values for a given concentration interval. Interestingly, we observed that most patient values were lower than spike plasma values, suggesting an underlying hypercoagulable state in some patients. The relationship with ETP was still statistically significant for patients on apixaban, but not on rivaroxaban, as already found in other settings. Here are shown the percentages of inhibition using thromboscreen region in the presence of thrombomodulin, thus involving the protein C system. Adding thrombomodulin markedly reduced PIC8 and ETP as expected in a xaban concentration dependent manner, again with inter-individual substantial variability. We then sought to identify the influence of patient characteristics on xaban concentration at Tmax and Tmin. In patients on rivaroxaban, the intake of amiodarone and of a CYP3A4 inhibitor other than amiodarone was significantly associated with an increased concentration at Tmin. In patients on apixaban, female sex and the amiodarone intake were significantly associated with an increased concentration at Cmax in univariate analysis. However, the main contributor of concentration variability at both Cmin and Cmax was the apixaban dose regimen in both univariate and multivariate analysis. We then sought to identify the influence of patient characteristics on Xaban peak height using thromboscreen without thrombomodulin. In the rivaroxaban group, in univariate analysis at Tmax, the decrease of creatinine clearance and the presence of heart failure were associated with a decrease of peak height. At Tmin, the increase of rivaroxaban plasma concentrations and the amiodarone intake were associated with a decrease in peak height. In multivariate analysis, creatinine clearance was the only variable that was associated with P8 at Tmax. Finally, in the apixaban group, besides the amiodarone intake at Tmin, apixaban plasma concentrations were the main determinants of P8 both at Tmax and Tmin in univariate and multivariate analysis. So this is, to our knowledge, the first academic study assessing specifically Xaban PK and PD variability in a real-life cohort of well-characterized, very elderly AF patients. The mean age was 87 years. They had substantial comorbid conditions and were polymedicated. We provide new data on plasma concentrations in this age group. When compared to patients included in a pivotal randomized clinical trial, we observed a much greater variability, mainly at Cmax in the rivaroxaban group, and both at Cmax and Cmin in the apixaban group. And these data are in agreement with the data obtained in real-life patients, but that are about 10 years younger than our patients. Predictors of PK variability were amiodarone and CYP3A4 inhibitors other than amiodarone in the rivaroxaban group, and they were significantly associated with Cmin. In the apixaban group, dose regimen was significantly associated with Cmin. TG assessed with histigenesia system provided reliable results under different experimental conditions, mostly significantly associated with apixaban or rivaroxaban concentrations in these patients, as already shown in different settings. At a given DOAC concentration interval, we observed a high inter-individual variability of TG parameters, especially of P8 measured with a thromboscreen. Under using spike experiments, we were able to evidence an underlying hypercoagulable state in some elderly patients, thus leading to variable anticoagulation intensities. Predictors of P8 variability were creatinine clearance in the rivaroxaban group that was significantly associated with P8 at Tmax, and in the apixaban group, plasma concentration were significantly associated with P8 at both Tmax and Tmin. These results highlight the need in the very elderly to carefully choose the DOAC regimen according to recommendations, to be aware of renal function worsening, and to be aware of drug-drug interactions. Our study has several limits. It was an exploratory study with a limited number of patients and samples, and so these results have to be confirmed in a greater cohort. Most patients were hospitalized, and the results are not directly extrapolated to outpatients. Thirdly, we found no association with clinical events, but events occurred within a median time interval of 3.4 months. Our perspectives are to build a PK model using a PK population approach in order to better understand DOAC profiles in the very elderly. I would like to especially acknowledge Geoffrey Foulon-Pinto, Georges Jourdi, Professor Thomas Lecomte, and all physicians who participated in the study. Thank you for your attention.